On behalf of the University of Miami, Division of Continuing and International Education, I would like to welcome everyone to the Allergy, the Flu, and COVID-19, Understanding the Difference and the Link to Cardiovascular Disease. I am Desiree Young, Executive Director of Programs and Enrollment Management here at our division. Today, we are excited to share with you a wealth of information from an esteemed panel. This webinar has been brought to you through our Division of Continuing and International Education. We offer many programs that provide an opportunity for you to reskill, upskill in a very competitive workforce. We offer over 70 credit and non-credit programs in a vast array of industries and professions, including healthcare. So, with that, we want to provide continuous learning at every stage of your lives. You can learn more about our program by visiting dcie.miami.edu. You can also connect with us through social media platforms. As you see here, we are very active. You can find us on Twitter, Facebook, Instagram, and LinkedIn. We're constantly sharing information, trending topics, and you can connect with the U community. So please sit back and enjoy this webinar for 60 minutes, which will provide you valuable information on our topic. And don't worry, if you cannot stay for the entire webinar or get disconnected for some reason, or would like to hear more information on the information that you heard today, this session will be recorded. You will have an opportunity to ask questions at the end by submitting them in the Q&A feature. So please, throughout the presentation, you can do so. We will be sure to get to as many as we can at the end of the presentation. Our webinar today will provide you with information on the relationship between allergy and COVID-19, as well as the relationship between allergies and cardiovascular disease, the adverse health effects of untreated and poorly controlled allergies, COVID-19 and cardiovascular disease in women. And remember, you will have that opportunity at the end to ask those questions. Now it is time for me to introduce our first speaker this evening, and that is Dr. Frederick Paulin. Dr. Frederick Paulin is a researcher, surgeon, professor at the University of Miami Miller School of Medicine, and practitioner with more than 30 years of experience in practicing allergy evaluation and immunotherapy. Dr. Paulin is certified by the American Board of Otolaryngology, Head and Neck Surgery. He was the president of the American Neurotology Society, a consultant to the Surgeon General United States Air Force, and has several society memberships. Dr. Paulin is published in multiple peer-reviewed publications and 4 books, which includes an Atlas of Computerized Tomography of the Head and Neck, and Allergy Evaluation and Treatment for the Family Practitioner. With that, here is Dr. Paulin.
Thank you. Let me my side, all right. We're going to talk today about allergy and viral disorders such as upper respiratory infections as well as COVID-19. I am a consultant for MedScience Research Incorporated. This series is going to talk about the socioeconomic impact and the pathophysiology of COVID-19 as well as allergic rhinitis and the similarity between the two. We're going to talk a little bit about the ear, nose, and throat aspects of it, but also allergy as it applies to everybody. Part of the problem with allergy is that there are more than 50 million Americans with allergic diseases, and it costs in the United States somewhere around 50 million to $100 million, $1 billion per year. It is the sixth leading cause of chronic disease in the United States, and it's the leading cause for children. Allergic rhinitis, asthma, and atopic dermatitis are the primary problems that we're looking at. In COVID-19, which is a coronavirus, we have today over 6 million people in the United States affected and well over 180,000 deaths, expected to be higher. Forbes has said that the long-term cost to the economy will be $8 trillion. And at the present moment, we are spending $1 billion a week for testing. What I'm going to do is go through the symptomatology that we have with allergies, COVID-19, influenza, and upper respiratory infections. I think the most important part is whether or not there's a fever. In allergies, we do not have fevers. In COVID-19, influenza, and upper respiratory infections, we may have fever. But 30% of the people with COVID-19 do not have a fever. As far as loss of taste and smell, you may lose taste and smell in allergic conditions, and you will, 50% of the people with COVID-19 absolutely do have a loss of taste and smell. Recently, today, in fact, I heard of a doctor who lost hearing because of COVID-19 after the loss of taste and smell. He also got his taste and smell back, but his hearing stayed down. The cough is the most important. It's a dry cough, and it's interesting because there is a relationship between a dry cough of an ACE2 inhibitor as well, and there is some information that's been promulgated today and this week how the ACE2 inhibitors may indeed not only have a relationship with a dry cough, but COVID-19 also uses ACE2 entryway into the cell, and consequently there may be a relationship there. And in allergy, we only have cough and shortness of breath with asthma. As far as fatigue is concerned, in allergy we don't have fatigue, and in influenza we do, and moderate fatigue is found in COVID-19. We do have a problem with lack of sleep, giving patients with allergy a problem with fatigue in the day, but it is not a primary problem. Sneezing and runny noses with allergies, everybody knows that, but it is rare in COVID-19. You may have a runny nose and it may be stuffy, but most of the people who have it do not have a sneezing attack. It is rare also in influenza, but in an upper respiratory infection, the answer is yes. Itchiness is the big difference between any of them, and itchiness goes with in the eyes and the nose with allergy, but with nothing else. I have had a patient with a rash due to COVID-19. Other than that, I've not seen any itchiness. Headaches and aches and pains. In allergies, you may have pressure in the sinus, but other than that, no other headaches. With COVID-19, it's a primary symptomatology that people have. In influenza, you may have it, and in an upper respiratory infection, it's possible. Sore throats, you'll have a tickle in allergy, and you'll have a moisture, and in most cases, with a sore throat in COVID-19, influenza, and in upper respiratory infections. Diarrhea, it's possible if you have allergy to foods, and in the COVID-19, 12% of the people have an attack of diarrhea and do have a viral spread approximately 40% of the time. The antibiotic classification is very important, and this is where the evaluation of patients is primarily to determine whether or not the individuals have an immune system problem, or if they have had the coronavirus. what we're interested in primarily is IgE, and IgE is the primary immune globulin that affects allergy. IgG and IgM are both found in all immune problems, but in COVID-19, it's part of the evaluation that we have for whether or not a patient has had the disease. When we have an antigen goes through the mucosa to an antigen presenting cell, which in turn can then go to a T helper cell 2 and stimulates the B cells, which in turn go to produce plasma cells, which then produce antibodies, and the antibodies of E, G, or M. This is utilized especially in the situation where the patients have allergies. It's important to realize that allergy, when treated with immunotherapy, is taking full advantage of this system. In other words, an antigen cell, when on stimulation with immune globulin E, produces a response in the Th2, the helper cell 2, which in turn then releases chemicals, IL-5, IL-8, IL-10, IL-4, which in turn is allowed to produce a change in the mast cell, which releases histamine. And that is what causes your allergic symptoms. When we treat a patient with immunotherapy, the antigen presenting cell is then caused to overproduce with the T regulatory cells, which in turn produces IL-10, which then produces an increase in IgG, Ig4, which is a blocking antibody, and the T reg cells also will inhibit T2 cells. When the T2 cells are inhibited, you have less of an allergic reaction. The proposed immune response that we see with COVID-19 is changing daily. Last week, we thought we had a storm of the cytokine storm, and this week they say, according to the individuals who've been doing research on it, that the cytokine storm is not really as important as some of the other chemical reactions. What we do look at is an antibody results, and we're looking at the viral load of the patient who was exposed to the virus here, and anywhere from 7 to 14 days develops the disease of COVID-19. At that point, IgM is started to be produced and IgG is produced. And we use that to tell whether or not the patient has had an attack of COVID-19. What we have here is we have a section of virus testing. The FDA has approved for virus testing 153 different tests. Not all are equal and not all are as accurate as some of them. There has recently been an antigen testing which is approved by the FDA. Abbott Laboratories and Abbott Diagnostics has produced a card which can be tested in schools and in your office or anywhere, and it does not take a lot of equipment. So the test is done, and it's within an antigen testing is done within 15 minutes. Serology tests, the IgM and IgG, some of them are approved and some of them are not approved. So we have to be careful as to which we test. What we have found is that the best testing is an antigen test and a serology test together. If they are positive, then we know that the patient has had the disease. There have been a lot of patients who've been reported as having negative response who have the disease, and a lot of patients who have positive responses who really probably did not have the disease. The immune assay of an IL-6 is done in order to determine whether or not the patient is having a cytokine storm. We're talking about rhinitis. Allergic rhinitis is most important. It is the IgE-mediated inflammatory condition with an allergen exposure in a sensitized individual. This is important because allergic rhinitis is not going to occur in anyone who's not been exposed. So we are going to look, and Dr. Herman will look at this through the other problems that can be associated with allergic rhinitis. The management of allergic rhinitis is very simple. It's stepwise, with a mild intermittent, a moderate, or a mild persistent, or moderate severe persistent. You start with the treatment in patient education and in allergy avoidance. That's more important than anything. Then you may use a few days of an intranasal steroid or an oral decongestant or an oral or local non-sedating histamine antagonist, antihistamine. After a moderate, severe to mild persistent, we use intranasal steroids or intranasal antihistamines. If that doesn't work, we use immunotherapy. Immunotherapy can be determined by either in vitro with immunoassays or in vivo skin tests. We utilize skin tests because they're much more accurate, and we also have a result within 20 minutes. Now, people have asked in the past, how do I take care of a patient who's getting injections and because of the COVID-19, they have not come into my office for a week or 2 weeks or even 2 months? So the answer is up to 7 days, we treat them as scheduled. If they have missed 8 to 13 days, then you repeat the previous dose. If they've missed 14 to 21 days, you miss the schedule injection, then reduce the dose by 25%. And at 21 to 28 days, you reduce the dose by 50%. A maintenance schedule, somebody has been coming in every 1 to 2 months. If they miss 1 to 2 months, you cut the dose 50%. And if you continue with a standard treatment. If they have missed more, you start at 0.05 cc's and advance, but watch for a reaction. If they still have a reaction, you have to retest the patient and start again. Thank you.
Thank you so much, Dr. Pollan. That was great information. I am sure that the listeners learned so much from those visuals that you provided. At this time, I would like to remind them as well to put your questions in the Q&A because we will be answering at the end of this session. Now, I would like to take the opportunity to introduce Dr. Bijan Herman. Dr. Bijan Herman is an assistant professor in the Department of Otolaryngology at the University of Miami Miller School of Medicine. After completing his undergraduate studies at Yale University, Dr. Herman attended medical school at Columbia University's College of Physicians and Surgeons and subsequently completed his residency at the University of Miami. He is a diplomat of the American Board of Otolaryngology and an active member of the American Academy of Otolaryngology, Head and Neck Surgery. Dr. Herman also serves as Director of Otolaryngology Services for the University of Miami's Palm Beach County Satellite Clinics. Dr. Herman.
Thank you very much. I just need privileges to share my slides. I think I have to be given the share privileges to put these up. So thank you very much. The last time Dr. Pullen and I gave a presentation together, there was no COVID-19 to worry about, and this was just medical and surgical management of allergic rhinitis and sinusitis. Now adding amidst COVID-19 changes a lot of things. To start with, I'd like to present two case studies, which we may have seen long before the pandemic started as well. One is a 61-year-old woman that Dr. Pullen took care of with a history of seasonal allergies, several days of nasal congestion, runny nose, mild intermittent cough, which she thought was due to allergies and postnasal drip, denies any fever or shortness of breath. And the second is a 40-year-old woman who had loss of smell and decreased taste over a few days, had no other symptoms. So these days, who do you think was the patient with COVID-19? I think most people, knowing that loss of smell and taste is an issue, would probably say the second. But in fact, both of these patients had COVID-19. And I think the key is that the 61-year-old woman's husband had COVID-19. So it's very important to ask history, because something that seems very straightforward, like allergies, can manifest as another disorder, including COVID. So bringing patients into the office where they might be exposed, or where someone might expose your staff or other patients to COVID-19 is kind of a big issue. And I think history and screening are key here. Most of the time we can put off some of our elective in-office visits. Telemedicine is a great adjunct to our practice now, because we can see new patients or established patients and talk things over with them directly. And we're now able to come up with a good plan, trial medications without making the patient come to the office right away. And I think that even if the pandemic subsides, we'll still be using that to help patients from afar. When in doubt, test the patient. Always use universal precautions if you're going to be doing aerosolizing procedures or seeing patients where you don't really have an exact etiology, because there's still a lot of unknowns around aerosol generation. The study that you see above shows that office laryngoscopy did not produce a high amount of aerosols, but I think nonetheless, when you're looking in the upper aerodigestive tract, it is important to use the right personal protective equipment, even if some of these studies show that you're not having the same aerosolization as we thought may have occurred 6 months ago. Allergic rhinitis and asthma, rhinosinusitis, these all kind of overlap. It's important for us to understand that allergies really are at the center of a lot of the sinonasal disorders that we take care of as ENTs. So when treating allergic rhinitis, nasal steroids, either sprays or washes, saline irrigations, and oral antihistamines are at the forefront of what I start with. I often use nasal antihistamines with a lot of success in patients with allergic rhinitis. Oral steroids I try and avoid as much as possible due to the side effects, but sometimes they're necessary, especially in polyp patients. But steroid washes can work just as well as oral steroids, especially in patients who have had surgery before and have open cavities where they can get to them. Of course, there's immunotherapy after allergy testing. Dr. Poland touched on that. And then there's in-office procedures like turbinate coblation, which can help reduce some of the swelling in the nose using a radiofrequency wand. Here we see the nasal cycle and the mucociliary clearance that gets blocked up. You see one side is open and there's drainage, and the other side, probably due to allergies, is blocked. The turbinates are hypertrophic and enlarged, and this swelling ends up leading to blockage of the sinuses and sinusitis, either acute or chronic. So predisposition for sinusitis, upper respiratory tract infections, and allergies really lead the list. Of course, there's a number of other things such as immunodeficiencies that can play a role as well. So acute rhinosinusitis, you see that in the you mainly have viral sinusitis, and you don't want to treat that with antibiotics. That's a big issue that we try and educate the public on, because in the first few days, you don't want to just give a patient a course of antibiotics. It's mostly viral, and these days with COVID-19, some nasal congestion, sore throat, postnasal drip may very well be a viral infection. And when do we start to think that it's bacterial? Well, there's two things that can happen. One is what we call a double worsening, where patients get better and then suddenly they get worse and have thick drainage and facial pressure and pain. The other is if they never really get better and it stretches out to about 10 days, and then we want to treat for acute sinusitis. Treating is sometimes with an oral antibiotic and nasal saline, and sometimes if there's a lot of inflammation, with a steroid spray or even an oral steroid. Chronic sinusitis lasts for more than 3 months. This is when you have these symptoms of facial pain and pressure, loss of smell, discharge, nasal discharge, nasal obstruction and congestion, and they persist. Acute recurrent sinusitis is when you have those acute infections for 4 or more times during the year, but in between the symptoms clear. In chronic sinusitis, you also need to have endoscopic and CT changes that show inflammation. Treating chronic sinusitis is somewhat similar to acute sinusitis. Nasal irrigations and topical steroids are great. Longer courses of antibiotics, sometimes 3 or 4 weeks, are used, and then we culture the nose to make sure we're treating the correct pathogen. When medical management fails, we move on to surgery. One thing that we can do in the office is dilate with balloons. These are instruments that we insert into the sinus openings to dilate them and allow the sinuses to drain. They're not indicated for polyps in general, but many times if allergies are just leading to chronic sinusitis due to inflammation of the sinus outflow tracts, we can use them to dilate. Here we have a video of a balloon procedure. And you see at the top, the right frontal sinus is blocked. Of course, this is a CAT scan, so the right is on our left. After this balloon is inserted and dilated in the frontal sinus outflow, another CAT scan was done. There you see the dilation is done. Another CAT scan was performed, and you see that sinus is cleared of the inflammation and blockage due to the dilation. Well, what about with polyps? You see on the tops of this slide a CT scan where there are nasal polyps, and you see the endoscopic view, going back, of nasal polyps in the nose. The turbinate is the nice pink, healthy-looking tissue there, and then the polyps are these sort of pale areas in the nose. Sometimes when turbinates get inflamed due to allergies, they can be mistaken by patients for polyps because they're so swollen and their nose seems so blocked. This lower CT scan shows allergic fungal sinusitis, a big fungal ball. That is usually a reaction to fungal spores, and it usually requires surgery. These big balls of mucinous, peanut butter-like material build up and need to be removed, and that can be a manifestation in our allergy patients. Allergic polyps also often require surgery, but we sometimes are able to treat them with medication, steroid washes and topical steroids, as well as there are some patients who are reacting well to immune modulators such as Dupixent, which is new on the market these days. Here you see one of the bigger sinonasal polyp surgeries. A lot of patients will have loss of smell due to nasal polyps. And with loss of smell being such a prominent issue in the COVID-19 era, many patients get quite worried if they lose their sense of smell, and sometimes it's polyps. Usually with polyps, you'll have a lot of nasal congestion, and it will have built up a little bit more slowly than with viral illnesses that cause loss of smell. We're able to remove those with sinus surgery endoscopically. And the picture on the right side of the screen shows an open sinus cavity, which we can surveil and clean in the clinic as needed. So speaking of loss of smell in the COVID-19 era, there have been several radiologic studies. This one shows some microhemorrhages in the olfactory area. There have been other studies that show that COVID-19 seems to attack the support cells around the olfactory bulb. These are important to pay attention to. We do MRIs if people don't recover their smell within a few weeks. The patients that I see with COVID-19 for loss of smell, I usually delay their trip into the office, but I still, once they've recovered, want to do a nasal endoscopy to make sure their loss of smell is indeed due to the viral insult to the olfactory bulb rather than something else that is flared up with a viral infection, such as nasal polyps. Of course, this does complicate our management of allergy, but as I said, I've been able to be pretty successful with combining telemedicine and a good screening practice in order to take care of patients with allergy during the last 6 months. Quite a number of patients want to get rid of their allergy these days, so I think that it's something for every practitioner who sees patients for allergy issues to remember. People don't want to have a cough these days. They don't want to have a lot of nasal congestion and sneezing because it can be somewhat stigmatizing. Thank you very much.
Thank you so much, Dr. Herman. That was really interesting. Watching the videos within the presentation as well, it really brought it to life. At this time, I would like to introduce Dr. Sanchez Gonzalez. He is a graduate medical education administrator and vice president for research and academic affairs at Larkin Community Hospital. He has developed a program aimed at educating medical residents in research as part of their graduate medical education experience and is part of the National Institute of Health's programs to increase diversity among individuals engaged in health-related research, PRIDE. Dr. Sanchez Gonzalez has conducted research in both university and hospital settings on quality improvement, patient outcomes, and physician burnout. His interest is behavioral cardiovascular medicine. Dr. Sanchez Gonzalez, you may present.
Thank you very much, Desiree, and thank you, Dr. Pullen and Herman, that they have set the tone in a very nice way to talk about the allergies. But now we're going to go on the underlying causes and overlooked topics when we talk about allergies, and perhaps patients that are not under control. So I want to take the chance to take a look at this first testimonial. And at the same way, we have a mask these days that cover up our faces, and we know that pretty much less than 10% of language it's basically nonverbal. We cannot unveil, we can understand what things are happening beneath the surface when it comes to COVID-19 and how it's affecting our patients. So as we remove the masks and we look into certain complications that have to do with management of chronic conditions, this case right here, it's very, very typical these days. And unfortunately, as of lately, we were having increased cases of patients with chronic conditions that they have not been treated for the last month. And those are the patients that are now hitting our emergency rooms of our hospitals. So we have a crisis with COVID-19, and we have the crisis within the crisis, which are, and in the context of allergy, this patient, luckily, he did very well at the end. But in essence, what happens when we have patients with allergic disorders, and these allergic disorders are not taken care of? Are we basically having a ticking bomb for having a new patient or cardiovascular patient? So that's the main question that we want to answer throughout today. With some of the objectives in this presentation, as I mentioned before, is just to tip of the iceberg, understand some of the underlying mechanisms that can explain the relationship between poorly controlled allergies, allergic processes, and cardiovascular disease. So I'm going to separate them in two main areas, basically the acute phase of allergy versus the chronic. But then that sustained chronic phase, how they can basically provide the substrate for cardiovascular disease. Then we're going to try to tie them together, see what happens with allergy diseases and how they direct into cardiovascular disease. And so briefly going to touch upon some therapeutic implications. So in terms of allergies and cardiovascular disease, still we have cardiovascular disease number one cause of death in the United States. And allergy, it's so common that pretty much over 40% of people, they basically report at some point of their life they have some kind of allergy. Now, when we look specifically into the association between cardiovascular disease and allergies, there's a link associating both. Higher allergies, more cardiovascular disease. And we know that the simple denominator, the simple way to understand this relationship is inflammation, uncontrolled inflammation. So also the heart, which we don't relate to a immunologically active organ, is in fact also immunologically active. It has mast cells, among others. We're going to explain a little bit about that. So by the end of the talk, hopefully we're going to have a little better idea and understanding how these two are treated. And if I'm trying to get my cardiovascular patient better and their allergies out of control, probably I'm not going to accomplish that final goal of decreasing cardiovascular disease. So we start with the acute and chronic phases. This is immunology 101, basically for allergy. In terms of the acute phase, anaphylaxis, which is the most dangerous one, relatively uncommon, it is interesting to know that what really kills the patient is a cardiovascular manifestation, hypotension, and the hypotensive shock that happens owing to the anaphylaxis. Now, mast cells are also located in the heart, and they have some physiological functions, specifically in circulation and other immunological functions. But many of these mediators, they don't really differentiate versus this is a actual emergency or this is an allergic process. So these specific immunological mediators, they can affect cardiovascular function in a acute way as anaphylaxis and also chronically. So when we move on into the chronic manifestations of disease, leukocytes, eosinophils, and cells that are from the immune system and also related to the immune response in allergies, they affect directly the vasculature and the heart. So it's very interesting to note that eosinophils, they produce substances that induce some vascular injury. So if we have anaphylaxis again, that the most serious complication is cardiovascular and death, but if we simplify things here, we have these mediators specifically as histamine, leukotrienes, platelet activating factors. But I want to tell you a story about kinase that is also secreted by these mast cells. Kinase also have very strong angiotensin II converting activity. Even if you have your cardiac patients on very good angiotensin II blockers, if you have the allergies out of control, the effects of those are not complete. So you have an allergic patient or a cardiac patient with allergies out of control, and you are inducing or you cannot have the full protection of the medications you're using. Now, again, this is the extreme case of anaphylaxis, which really much doesn't apply much on all control allergies, but the repetition at the chronic phase of these same processes with time leads to the formation of atheromas. And in terms of cardiovascular physiology and cardiovascular risk, the main advancement in the last 10 years has been the recognition of inflammation in the immune system as a major key player in the formation of atheroma plaques. In fact, I can take cholesterol or put cholesterol in. I can take several of the other risk factors that have been recognized, and inflammation triumphs in terms of deposition of that atheromic plaque. So these activated mast cells owing to poor control allergies, plus the effect they have on the eosinophils, which is very intriguing to me because these crosstalk that we call allergic effector unit, they influence each other. And in this back and forward, things like this can happen. Additional deposition of extracellular matrix, increasing arterial stiffness of central arteries. Central arteries increase arterial stiffness. It's a well-known cardiovascular risk factor. So one allergic event may not be enough, but sustained chronic allergic inflammation can basically end up affecting the cardiovascular system. And that's the main point that I want you to take into consideration today. If you want to get one point from this talk, is if I want to get my cardiac patient better, if their allergies are not under control, it's going to be very hard to accomplish that. If I want to have my allergic patients out of cardiovascular risk and a second complicated disease, I want to maintain the compliant and controlled. So this chart basically summarizes what are the most common mechanisms associated with allergies and the pathophysiology of cardiovascular disease. Some of them are very easy to recognize here, like IgG and mast cells. How these pro-inflammatory substances lead to endothelial damage. The endothelial is being recognized as the largest organ of the body. So if we start damaging the endothelial cells, we are getting into basically trouble all across the board in terms of circulation problems. Corticosteroids and beta-2 agonists that are used extensively in some of these patients because we don't have those allergies under control. We haven't identified the allergens. Basically can lead to metabolic syndrome, among other things. Tachycardia, increase what we call myocardial oxygen consumption, which is not a winning formula if you want to keep your cardiac patients out of the hospital. Also, vitamin D that decreases in some other vitamins and minerals, but vitamin D is intriguing because it has some kind of anti-inflammatory properties. The allergic processes basically decrease vitamin D levels. These decreased levels are associated with cardiometabolic disease, aka insulin resistant, among other states. This is very important to consider that pretty much allergy might not be recognized as of today as a major cardiovascular risk factor, but it's a very important mediator, especially when we have it outside or poorly controlled. Now, as I'm very mindful of your time, closing out, I just want to mention that the perspectives on treatment of allergic disorders and cardiovascular disease have to consider and take into consideration close monitoring of those patients using wearables, for instance. We need to look at more sensitive technologies to measure cardiovascular risk factors. We're not talking about your common blood pressure. We're talking about central blood pressures. We're talking about arterial stiffness measurements. We're talking about non-invasive ways to monitor coronary perfusion. Those from a primary care perspective could be accomplished these days. More aggressive testing and training for people in the primary care, also specialists, to identify the source of the cause of that particular allergen that is getting my patient out of whack. And again, more aggressive or better target pharmacotherapy that can address both issues and could be protective. There's an example with some statins that have been shown to have protective effects, especially in those who has uncontrolled allergies, and they want these statins provide some kind of protection to them. So in some poorly controlled allergic patients, these are a ticking bomb, basically, and they are progressing faster towards cardiovascular disease, the #1 cause of death. Also, patients that are under cardiovascular disease, we need to pay attention to them when their allergies get out of control. Potentially, we're not controlling the cardiovascular manifestations of the cardiovascular disease. Appreciate the opportunity. Thank you very much.
No, thank you so much, Dr. Sanchez-Gonzalez, for that interesting presentation combining allergies and cardiovascular together in one conversation. Thank you. At this time, our division would like to recognize the American Heart Association for taking the time to participate in our sessions here today. We have with us Mr. Robert Hill Jr. Mr. Hill Jr. serves as Vice President of Health Strategies at the American Heart Association, where the mission is to be a relentless force for a world of longer, healthier lives. Hill has more than a decade of experience directing healthcare promotion and disease prevention campaigns in nonprofit, academic, clinical, and governmental arenas. In his role at the American Heart Association, he leads clinical strategies to reduce chronic conditions, advocates for community policy changes to improve health, and partners with community-based agencies to serve the South Florida community. Hill earned his master's degree in public health from Nova Southeastern University and his bachelor's degree in psychology from the University of Florida, where he participated in health psychology research for reducing barriers in asset-limited minority population. Mr. Hill, thank you so much for joining us.
Yeah, of course. It's a pleasure to be here. I'll just make sure that I'm sharing. All right. All right, thank you. Yeah, and it's also great to be the only non-physician on this call, so hopefully I'll be able to give a little bit of a different perspective to everyone here. So I will be talking about COVID-19 in relation to cardiovascular disease, and then I'll also talk about how that impacts women's health. So first, I want to briefly start off with who we are, the American Heart Association, and why we do this work. It was already mentioned that heart disease is the #1 killer of Americans and worldwide. We all know someone who's been impacted by heart disease, a friend or ourselves or a family member. And we do so much as an organization to try to impact this space. We funded the first heart valve. We do more CPR training than any other organization in the country or the world. One area specifically is we focus on research. So we funded as an organization over $4 billion in research, 13 Nobel Prize winners. And I mention that because when it comes to COVID-19, we've actually funded currently and immediately $2.5 million to investigate the cardiovascular implications of coronavirus. So it was mentioned in my bio that we have clinical engagement strategies that I help to oversee in South Florida. These are two of them, cholesterol management and hypertension management, affecting huge numbers of the American population. And some of what we've been trying to do around COVID-19 response is to go into clinical settings, federally qualified health centers, those who might need this most, both clinical care teams as well as patient populations, and go in and then offer support, both on how to best utilize telemedicine, but also to monitor, similar to the government system of where coronavirus cases are occurring. So when we look at who is most affected in terms of cardiovascular disease, we do see a full 40% of those hospitalized had cardiovascular disease or cerebrovascular disease. And 23% of those hospitalized for COVID-19 have serious cardiovascular complications. Now, that doesn't even take into account the 12% who have acute cardiac injuries, so permanent damage to their heart from contracting COVID-19 and then being in the hospital. As was already mentioned, this is an area where those with the chronic conditions, people besides just coronary heart disease, but individuals who are 65 and older, folks with diabetes or who are obese, they're the ones who are most at risk for serious complications. And I will also say one of the big reasons that they're at risk for complications is just because was mentioned with allergies, any type of condition, there's a level of care that needs to be taken. And COVID-19 disrupts in its entirety regular care that a patient would be able to administer themselves, whether it's not being able to go see a regular healthcare practitioner or if it's just not being able to get medication or go out and get enough physical activity. And so all of those, unfortunately, lead to this domino effect of much more higher levels of problems, high blood pressure, increase in obesity. And so what I'll say is that there has to be a focus on going to physicians if there's a problem. Something that's very important to the American Heart Association is to not ignore symptoms, and it's unfortunate that folks are afraid or they're just uncomfortable going to interact with their physicians. But it's imperative, and especially in terms of life-threatening conditions such as a heart attack or a stroke, immediately to go get support from your healthcare team. Those why it's also an issue if you're contracting COVID-19. If you have these underlying or pre-existing cardiovascular disease, you're going to become sicker. I mean, it's just the nature of your heart already being under stress and not getting enough oxygen. So being mindful, absolutely, but seeing all the other issues in place, our organization has really tried to do what we can for leveraging our science and research, but also trying to meet the needs of our healthcare teams. I did mention briefly that we have clinical strategies, and we're trying a few initiatives out, some of which are here: oxygenation and ventilation of COVID-19 patients, free job aids, support on COVID-19 data registries, just anything to support with remote patient monitoring, because we do understand the dangers of those who, stroke survivors, people with high blood pressure, diabetes, they just face increased risks. And we're trying to do what we can. Mortality rates are somewhere around 2 to 3 times higher than they are in the general population for those who have those conditions. So it's something that we really want to focus on. And as I talk about populations that are more at risk for complications, I want to switch to the fair sex. And that's women. So when we talk about those who are disproportionately affected, a full 1 in 3 of women will die of cardiovascular disease. That's worldwide, slightly less in the United States. But we're also thinking about our healthcare practitioners, anybody who's out there on front lines. Just recently, the CDC came out and said that women comprise 73% of the U.S. healthcare workers who have been infected with COVID-19. That's staggering, and it just speaks to a larger issue that I want to highlight here. Women are our caregivers. I mean, that's the role. The women in my life have absolutely been that. My favorite doctor was a woman, partial to my mother. My sister's okay. Girlfriend's great. But I will say more than anything, though, it's that women have a tendency to take care of others instead of themselves first. We kind of like to think of it as like if you're in an airplane and the oxygen drops, you need to make sure you put your oxygen on first. And what's so unfortunate about women in cardiovascular health is a lot of the times the symptoms are different as well. They may be presented as an upset stomach or back pain as opposed to the traditional symptoms that a man might experience. So this is just an initiative that the Heart Association is locally hyper focused on, and we will be spending a huge amount of time in this space in the coming years. And I'm very happy personally to be working in this space. The last thing that I will highlight, because I am trying to hurry through here, are a couple things. So first, everybody can know your numbers, but for women, please, like, know your cholesterol, both your good and total, your blood pressure, blood sugar, and your BMI. Beyond that, though, people like myself, white males, we have been disproportionately represented in research. That's very unfortunate. And so we have an initiative called Research Goes Red. And you can actually go to this website, projectbaseline.com/go red, and you can register, put your information in if you'd like. The goal is to just create a database of more information that we can use to help women be more represented in cardiovascular, cerebrovascular research in the future. We don't want to see. Unfortunately, heart attack and stroke numbers are going up, and partially due to COVID-19, although they are incredibly underreported due to people not going to the hospital. But we don't want to see those numbers go up. So if anybody's interested in signing up, please, you can go here. And if you have any more questions, you can always reach out to me. I'm happy to connect with you.
Okay, great. Thank you so much, Robert, for that valuable information. I'm thanking you on behalf of the university and as a woman personally. Great information to have. And so what I would like to share with all of you at this time is our allergy diagnostic and allergen immunotherapy training workshop that we will be having in March. So having this webinar is part of that in terms of us providing information on this specific topic area. We actually do have a workshop. So if you'd like to learn more information on this, you can always visit our website at dcie.miami.edu, where you will be able to see all the highlighted information that you see here on your screen and much more. With that, I would like to let you all know, because you participated in the webinar here with us today, you will receive 10% tuition fee waiver for that workshop. We're very excited about it. It's very focused on the topics that you've heard here this evening, and it will be very, very valuable. You can go ahead and register at miami.edu/allergy. Or should you like to talk with someone in terms of gathering more information and how to register and detailed information about the workshop, you can call 305-284-4000 and speak with an enrollment advisor, and they will gladly provide you with as much information as they can. At the end of this, when we're finished, please take a couple minutes to fill out a survey that we do have at the end of this webinar here today. But I would like to take this time on behalf of the University of Miami, on behalf of Dean Rebecca Fox for the Division of Continuing and International Education, to thank all the panelists that we have here with us this evening. Thank you for taking your valuable time to provide us with all these information. We truly appreciate it, especially during the times that we're in right now. So thank you so much, and thank you for all those who took the time to attend the webinar, to listen to these information. Thank you so much, and have a good night and stay safe.